There is something your doctor never had time to tell you, and it is not because they didn't want to. It is because the system doesn't allow for it. You walked in, your blood pressure was high, a number was written on a chart, and somewhere between that reading and the parking lot, a small white pill became the entire solution. But what if that pill is only doing half the job and nobody ever explained what the other half looks like? What if the side effects you've been quietly tolerating, the swollen ankles, the mild dizziness, the fatigue that crept in so slowly you convinced yourself it was just age, were never inevitable at all? Stay with me, because what you're about to understand changes everything about how you see that little pill you've been taking every single morning. Let's start at the beginning, not with medication, but with a moment most people recognize immediately. You sat in a waiting room, you filled out a form, a nurse wrapped a cuff around your arm, pumped it tight, listened, and wrote down 2 numbers. Then a doctor came in, glanced at those numbers, and said something like, "Your blood pressure is too high. I'm going to start you on a medication." Maybe there was a brief explanation. Maybe there wasn't. Maybe you nodded because the white coat in front of you projected a certainty that made questions feel unnecessary. And then you walked out with a prescription, a 30-day supply, and absolutely no understanding of what was actually happening inside your body. That is where this story truly begins. Not at the pharmacy, not at the first pill, but in that gap between what was handed to you and what you were never told. The medication being discussed here is one of the most commonly prescribed blood pressure drugs in the world. Millions of people over the age of 60 take it every single day. It has decades of research behind it. It is not dangerous. For many people, it is genuinely life-saving. But here is the thing that almost no one explains in plain language. There is a significant difference between a medication working and a medication working well for your specific body. And that gap, that space between adequate and optimal, is where confusion lives. It is where unnecessary side effects happen. It is where doses quietly climb upward year after year. And it is where people sometimes stop taking something they genuinely need, because nobody ever explained what they were actually experiencing. So let's fix that right now from the ground up. Your arteries are not pipes. That is the first thing to understand, and it matters more than almost anything else. When most people hear the words high blood pressure, they picture a garden hose with too much water being forced through it. That image makes sense on the surface, but it misses something critical about what is actually happening inside your body. Your arteries are living tissue. They are surrounded by layers of smooth muscle, and that muscle is constantly responding to signals, contracting and relaxing thousands of times a day based on hormones, nerves, temperature, stress, sodium levels, and dozens of other factors. When you are young, this system works like a well-tuned instrument. Your vessels widen when they should, tighten when needed, and adapt almost instantly to whatever your body demands. But something changes with age, and it changes gradually enough that most people never notice it happening. The vessel walls begin to stiffen. Not dramatically, not all at once, but slowly over years. The smooth muscle surrounding those walls starts holding a slightly higher resting tension, like a fist that never fully opens anymore. And then there is the calcium factor, which is the part that almost nobody outside of cardiology ever thinks about, but which explains everything about how this medication actually works. Inside every smooth muscle cell in your artery walls, there are tiny channels that allow calcium to flow in from the surrounding fluid. When calcium enters those cells, the muscle contracts. The artery narrows. Blood has less space to move through, so the pressure required to push it through goes up. This is not a malfunction. This is how your vascular system was designed to work. The problem is that with age and certain health conditions, those calcium channels become overactive. Too much calcium flows in too often. The muscles stay contracted longer than they should. Pressure stays elevated even when your body doesn't need it to be. This is the exact mechanism the medication targets. It works by partially blocking those calcium channels in the smooth muscle of your artery walls. Think of it as reducing the number of open doors through which calcium can enter. Less calcium inside the cell means less contraction. Less contraction means the artery stays wider. A wider artery means less resistance to blood flow. Less resistance means lower pressure. The mechanism is elegant. The science behind it is solid. But here is the part that changes how you should understand your own experience with this medication. It is managing the output of a system. It is not changing the system itself. The underlying reasons your vessels became tight, the stiffness in the walls, the inflammation, the fluid balance, the hormonal signals, all of that is still present. The medication is working downstream, not at the source. And that distinction is going to matter enormously in a few minutes when we talk about why two people on the exact same dose can have completely different results. But first, we need to talk about something that happens in the first days and weeks of starting this medication, because this is where most people make a decision they later regret. When you first begin taking it, your body does not simply accept the change and move on. Your vascular system has been operating at a certain level of tension for months or years. The calcium channels have been doing their thing, the muscle tone has been set at a particular baseline, and then suddenly those channels are being partially blocked. Your body notices, and in noticing, it begins to recalibrate. This recalibration period is completely normal. It is expected, but it produces symptoms that, without any explanation, feel alarming. Some people feel flushing in the face, a warmth that rises without obvious cause. Some feel mild dizziness, particularly when they stand up too quickly from a chair. Blood pressure readings may fluctuate during this period, sometimes higher than expected, sometimes lower. Some people feel a vague tiredness that wasn't there before. And because nobody warned them that this was the adjustment phase, because nobody said this is temporary and here is why it's happening, many people interpret these symptoms as evidence that something is wrong. They call the office, they stop taking the medication, they convince themselves they had a reaction. And what actually happened is that they interrupted a recalibration process right before it was about to complete. They never gave the medication the chance to reach its stable, full effect. The body was doing exactly what it was supposed to do, and they walked away at the worst possible moment. The timeline for this adjustment is typically 1 to 2 weeks. That is not a long time, but it is an eternity if you are experiencing symptoms that nobody prepared you for and nobody is explaining as they happen. This is one of the most common and most preventable reasons that blood pressure management fails in the first month. Not because the medication doesn't work, because the patient was never given the information they needed to stay the course. Now let's talk about the side effect that genuinely concerns people the most, because it is visible and it is physical, and it does not go away on its own in the same way the early adjustment symptoms do. Ankle swelling. It happens in a meaningful number of people taking this medication, more commonly in women, more commonly in those who stand or sit for long periods, and more commonly as the dose increases. And when it appears, the fear it generates is entirely understandable. Your ankles are puffy, you look down and something has changed in your body. The first thought is often, something is wrong with my kidneys, or my heart is failing, or the medication is damaging something. None of those things are what is happening. Here is what is actually happening. When this medication relaxes the smooth muscle in your artery walls, it does so throughout your body, including in the smaller vessels in your lower legs. When those vessels dilate, more blood flows into them. More blood in the small vessels of the legs means more fluid pressure pushing outward into the surrounding tissue. That fluid accumulates. It does not have anywhere else to go, so it pools around the ankles. This is not your kidneys struggling. This is not fluid backing up because your heart is weak. This is a direct mechanical consequence of the medication doing exactly what it was designed to do. The problem is not the drug. The problem is that the redistribution of pressure has a visible effect in the most gravity-dependent part of your body. Understanding this does not make the swelling disappear, but it completely changes the conversation you can have with your doctor about managing it. Elevating your legs in the evening helps. Reducing sodium reduces the total fluid load in your system, which reduces how much fluid is available to accumulate. Compression stockings, worn during the day, apply gentle external pressure that counteracts the outward push of fluid into tissue. And in some cases, the dose or the timing of the medication can be adjusted in ways that minimize the effect. None of these conversations happen if you walk into the doctor's office and simply say, "My ankles are swollen," and leave with a different medication or no medication at all. And this brings us to something that deserves to be said directly. Stopping this medication without guidance is not a neutral decision. When you stop a drug that has been holding your blood pressure at a lower level, that pressure does not ease back up gently and gradually. In some cases, it rebounds. The system that was being managed suddenly has no management. The calcium channels that were being partially blocked are suddenly fully open again. Blood pressure can spike in ways that create real risk in the short term. This is why every conversation about adjusting, pausing, or stopping blood pressure medication needs to happen with a doctor, not in response to a symptom that frightened you, and not because you read something online at 2 in the morning. The fear is understandable. The solution is information, not cessation. Let's talk about sodium now, because this is where the story gets genuinely interesting and where most people have no idea how directly their daily choices are affecting whether their medication works well or works poorly. Your total blood pressure reading at any given moment is the result of multiple forces acting simultaneously. The medication is one of those forces, working to relax vessel walls and reduce resistance. But sodium is another force, working in the opposite direction. Here is the mechanism in simple terms. When sodium levels in your blood are high, your body retains more water to dilute that sodium and keep the concentration balanced. More water in the bloodstream means more volume. More volume means more pressure against vessel walls. The medication is trying to reduce the resistance in those walls. Excess sodium is simultaneously increasing the volume of fluid pushing against them. You are fighting yourself. This is the hidden reason why two people on the exact same dose of the exact same medication can have completely different blood pressure readings. Person A eats relatively low sodium, cooks at home, reads labels, and manages fluid intake reasonably well. Person B eats processed food regularly, adds salt at the table, and doesn't think much about it. Both take their pill every morning at the same time. Person A's blood pressure is well controlled. Person B's is still borderline. The doctor considers increasing the dose, but the dose was never the problem. The environment in which the dose is operating was the problem. The medication cannot compensate indefinitely for a system that is constantly pushing against it. And there is something even more insidious that happens over time, something that catches many people completely off guard. In the first weeks after starting blood pressure medication, most people take the adjustment seriously. They watch their diet. They check their pressure regularly. They take the pill without fail, and then the numbers improve. The readings come back lower, and unconsciously, gradually, the vigilance fades. Diet loosens. The morning walks become less frequent. The salt shaker comes back to the table. The evening snacks get saltier, and the medication is still doing its job, masking the rising pressure signals being generated by all of those changes. The numbers on the monitor look acceptable, but underneath them, the system is working harder and harder to produce that acceptable number, until one day, it isn't enough anymore, and the dose needs to go up. And everyone assumes the body just got worse, when in reality, the body was never given the support it needed in the first place. This is one of the most important things to understand about long-term blood pressure management. The medication is not a solution that you take and then return to your previous life. It is a tool that works best when the environment around it supports what it is trying to do. Vessel stiffness is influenced by chronic inflammation, which is influenced by diet, body weight, and activity level. Fluid balance is influenced by sodium and hydration. Daily pressure swings are influenced by sleep quality, stress, and caffeine. None of these things are addressed by the pill. The pill handles one specific mechanism, and a very important one, but one out of many. When the others are working against it, the results are predictably mediocre. When the others are aligned with it, the results are often remarkable with far lower doses. There is also the question of how blood pressure is measured, and this matters more than most people realize. A single reading in a clinical office is not your blood pressure. It is your blood pressure at that moment in that environment, with the anxiety of a medical visit, after however many hours of sleep you had, having eaten or not eaten, having exercised or not exercised, and possibly having drank coffee an hour earlier. Blood pressure is not a fixed number. It rises and falls throughout the day in response to everything your body is doing and experiencing. Morning readings are typically higher. Evening readings are typically lower. Stress causes spikes. Deep breathing causes drops. A single office measurement taken by a stranger with a cuff and then used as the basis for dosing decisions is a profoundly limited data point. This is why home monitoring matters so much, not to create anxiety, but to create accuracy. When you measure your blood pressure at home, at the same time each day, after sitting quietly for 5 minutes, without having eaten or exercised or caffeinated yourself in the prior hour, you get a much more honest picture of where your average pressure truly sits. And when you track that data over days and weeks, you begin to see patterns that a twice-yearly office visit could never reveal. You see that your pressure spikes on days when you slept poorly. You see that it drops on mornings after low-sodium evenings. You see the effect of a stressful week. You see the effect of a walk you took 3 days in a row. This information is not academic. It is actionable. It tells you exactly where your leverage points are. And yet most people taking blood pressure medication have never been shown how to use a home monitor correctly, have never been told what patterns to look for, and have never had a conversation with their doctor that went beyond a 2-minute review of office readings. The technology exists, the knowledge exists, the willingness exists in patients who are often far more motivated to manage their health than the healthcare system gives them credit for. What is missing is the bridge between the prescription and the understanding. And that is precisely what this conversation is trying to build. Let's talk about age specifically, because this is where blood pressure management becomes more nuanced and more important at the same time. The way a 65-year-old body responds to blood pressure medication is genuinely different from the way a 40-year-old body responds, and not in ways that are always intuitive. As we age, the nervous system's ability to respond quickly to positional changes slows down. When a younger person stands up from a seated position, the blood vessels in the lower body constrict almost instantly to prevent blood from pooling there and dropping the pressure in the brain. In an older person, this reflex is slower. It takes a beat longer. And if blood pressure medication is simultaneously relaxing those vessel walls, making them less responsive to the constriction signal, the result can be a momentary drop in pressure when standing that causes dizziness, lightheadedness, or in the worst cases, a fall. This is called orthostatic hypotension. It is not a rare complication. It is not a sign of a serious problem with the medication, but it is something that needs to be managed because falls in people over 65 carry consequences that are far more serious than the blood pressure the medication is treating. The solution is rarely to stop the medication. It is to understand the mechanism. Take a moment before standing, hold on to something stable, let the body catch up, and mention it to a doctor so the timing and dosing can be optimized. A medication taken at night, for instance, means its peak effect occurs while you are lying down and asleep, reducing the risk of standing-related pressure drops during the hours when you are active. There is also the question of kidney function, which deserves a moment of honest attention. As kidneys age, their ability to regulate fluid and electrolyte balance changes. The kidneys and blood pressure are deeply interconnected in ways that affect how blood pressure medication behaves. A kidney that is not functioning at its full capacity may retain more sodium and fluid, creating more pressure load that the medication has to counteract. This is not a reason for alarm. It is a reason for regular monitoring, which most people on long-term blood pressure medication should be having anyway. Kidney function markers are simple blood tests that any physician can order, and that should be part of the routine conversation, not something discovered accidentally years into treatment. What all of this points toward is a single, foundational truth about managing blood pressure after 60. It is not a single variable problem. It never was. Blood pressure is the final output of a system that includes vessel wall stiffness, fluid volume, nervous system tone, kidney function, hormonal signaling, sleep quality, inflammation levels, dietary patterns, body composition, stress response, and yes, the calcium channel activity that the medication directly addresses. Managing only one of those variables and expecting stable, optimal results is like adjusting only one instrument in an orchestra and wondering why the music still sounds off. The medication is important. In many cases, it is essential, but it is one instrument. And the question every person taking it should be asking themselves is not just, am I taking my pill every day? The question is, what else is the orchestra doing, and is everything playing in the same direction? Because when the answer to that question is yes, something genuinely remarkable often happens. The readings stabilize at levels that require lower doses. The side effects diminish because the body is not fighting itself. The energy that the vascular system was spending on constant high-tension management begins to become available for other things. People report feeling better in ways they did not fully expect. Not dramatically different, but consistently better in ways that accumulate over months. The other thing worth addressing, honestly, is what happens to people who stay on this medication for years without ever having these conversations. They take the pill, they go to checkups, they get their blood pressure read, and if the numbers are acceptable, the conversation ends. There is no discussion of what's driving the numbers below the surface. There is no review of whether the dose could be lower with lifestyle support. There is no conversation about the ankle swelling that has been quietly worsening or the dizziness that has been slowly becoming more frequent. These things get attributed to aging, to being on too many medications, to genetics, and in some cases they are, but in many cases they are the predictable result of a system that was never given the full picture of what management actually requires. You deserve that full picture, and the picture looks like this: a medication that handles one specific but genuinely important mechanism in blood pressure regulation, a body that is doing everything else, generating all the other forces that determine what your pressure actually does, a lifestyle environment that can either support or undermine the medication's effect, a monitoring practice that tells you the truth about your real average numbers rather than a single snapshot, and a set of conversations with your healthcare team that go deeper than number on a chart, prescription refilled, see you in 3 months. The goal is not to make you suspicious of your medication. It is not to suggest that natural approaches alone are sufficient, because for most people with genuinely elevated blood pressure, they are not. The goal is to make you the most informed, most effective partner in your own vascular health, because the evidence on this point is clear and consistent across decades of cardiology practice. Patients who understand what their medication is doing, why certain symptoms happen, how their lifestyle choices interact with the drug's mechanism, and what warning signs actually require concern, those patients have better outcomes. Not because information is magic, but because understanding leads to consistency, and consistency is what blood pressure management runs on. Every morning when you take that pill, something real is happening inside your artery walls. Calcium channels are being partially blocked. Smooth muscle is relaxing. Resistance is dropping. Blood is moving with less effort through vessels that are a little bit wider than they would otherwise be. That is not nothing. That is a meaningful physiological intervention that is, for many people, the difference between a stroke and a normal Tuesday. But it is also not everything. And the space between what the medication does and what full management requires is where your understanding, your choices, and your daily habits live. That space is yours to occupy. And now at least you know it exists.